Hello and welcome to this latest edition of the MPFT podcast. Most often, the best place for a person to receive urgent care is in the community and, where possible, in their own home. A core aim of the new NHS 10-year plan is to shift care from hospital to the community, and the Integrated Care Coordination for Urgent Care Service, or ICC for short, works to do just that. For this episode, we'll be talking about how the service works to coordinate the care a patient in urgent need receives, with the aim of avoiding a hospital stay where possible. My name is Mark Fletcher from the communications team, and for this episode I'm joined by Angie Costello, Service Manager working in urgent care, and Anna Redpath, Clinical and Operation Manager for the service. Thanks very much for joining us, Angie and Anna. Really appreciate your time today, and very much appreciated. We'll jump straight into the questions. Angie, I'll give this one to you first, if that's okay. Now, we know that health and care systems aren't always the easiest to navigate, and we know how frustrating that can be for patients and also healthcare professionals. So could you talk a little bit about what the ICC is and why the job it does in Staffordshire and Stoke-on-Trent is important in addressing those particular issues?
Yeah, absolutely. I can answer that one, Mark. So the ICC for urgent care is classed as a single point of access. So the guidance that we've developed the service on is the national guidance for single point of access. The whole remit of that is that health and social care professionals, when they've got a patient that's got that urgent need, can phone one number. So the premise of the whole service is that there's just one number that folk can call into, and we will then be that one point of reference. We will then take the call from that person, whether it be a nurse in the community, an ambulance driver, whether it's a social care practitioner that's in the community. And these are people that are with patients that are normally quite poorly. They don't know if they need an ambulance or not at that point, and they will phone the ICC for urgent care on the one number, and we will take that call, we'll triage that call, and then that patient will hopefully not need to go to hospital. So as I say, the whole idea of the ICC for urgent care is that people know where to come, and we promote that one number in many different places. So, emails have gone out, lots of comms. We've got fact sheets, we've got infographics. We've met with tons and tons of the people that we work with, and that can be, as I say, the ambulance services are a real big one because they're people that are with those very, very poorly people, and then we take that call from that one number, and that's it. So yes, that's how we've got around it, is by having that single point of access.
And just a point of clarity, so when you talk about the single point of access, that's open for professionals, isn't it, rather than members of the public, for example? That the point of it is that the professionals call that number and then work with yourselves along the lines you've just described. Sure,
yeah. So at the moment it's professionals. We've opened that quite recently, actually, Mark, to include carers as well. Okay. So when we first took over this service in June last year, and by us I'm referring to MPFT, it was very much around professionals, around nurses, paramedics, social care practitioners. As part of the work that we've done over the last 12 months, we've now opened that up to include carers, but also somebody from a GP's practice can call. It doesn't have to be the GP anymore. Right. So that just takes the time from the folk that haven't got the time to make that phone call and hand it over to somebody else. So what we're doing is we're not saying no to any question. We're saying if we can't do it right now, that's okay, and we'll work on seeing if we can change it in the future. Okay. So there is a plan for the future to open up to patients, not to all patients, but specific cohorts of patients that might need that one number. Okay. And the future for the trust as well is it would be frail patients. So once we get a frailty service that we can then advertise, it's likely that it will be that they will be the people that can phone the ICC, because we're available during those 8 till 8 times, and they can come to us. There is overnight provision as well, which hopefully we'll get some opportunity, but that's not delivered by MPFT. It just means that we're hoping to get the same pathways that we've got in the daytime overnight. So it may come over to MPFT in the future, who knows, but right now we're 8 till 8 in the day.
And you've talked a bit there about patients and the kind of patients that we see and support and do that service, Anna. Could you just talk and give sort of a typical example of how the service supports a patient like the ones that Angie's just described?
Yeah, sure, thank you. So we have the healthcare professionals line, which Andy's just described, has been opened up to carers as well. But what would happen is a healthcare professional would call that line. So that could be a GP calling, paramedic on scene, so a paramedic in a patient's house with a patient. Our community staff and MPFT may call that line. Care and nursing homes across all of our footprint will also call that line.
Right.
And they're the people that are with patients that are unwell and they're looking for an alternative option to hospital, and a safe and appropriate alternative option to hospital or ambulance convey. Or sometimes people are ringing just to help connections to other services if they know that there's perhaps a service out there available that they've come across in the past but they're not quite sure how they get to that service. They can also ring us for that. So we focus on urgent care, but we try and do some of that other work around it so people can come to us if they are just, I suppose, stuck with what to do next with somebody for any of those reasons. Then we also support West Midlands Ambulance Service with their ambulance CAD portal. Some people may have heard of that referred to as the ambulance stack. So West Midlands Ambulance present to us on their portal, on their system, category 3 and 4 patients that have been, that people have contacted 999 because they feel they need an ambulance. They've been, an element of triage has happened with West Midlands Ambulance Service, and then those patients are live on a portal that we have the opportunity to call each patient individually and make a community triage to see if there's anything we can do to support that patient before sending an ambulance. So we have lots of pathways available within our service now that we've built up over the past 12 months. Some we are still developing. New pathways are always presenting to us, and we always take those opportunities so we can support that patient on a different journey, away potentially from conveyance by ambulance or hospital admission where it's safe to do so, and cancel ambulances where appropriate.
And you mentioned about category 3, 4, so would I be right in assuming that that's the higher category, so therefore, and as per the type of service that we provide here, more the higher urgency of need for that particular patient?
So that these patients won't have any life-threatening presentation, so that would still be an ambulance, and that would be decided by West Midlands Ambulance Service. So then they would pass the patients across to us of category 3 and 4 that would be suitable for support in the community.
Right, thank you. I'll stay with you, Anna, if that's okay. So my next question. The key aspect of the ICC is ensuring that the left hand, the right hand know what they're doing, so to speak, and by making sure that health and care organisations are working together, and you've mentioned a couple there, so a patient is supported the right way at the right time to avoid a hospital stay ultimately. Could you talk about that a little bit more, about kind of the work that's involved, the partnership element of this?
Yeah, so we've engaged with lots of people across our system, many MPFT services. We know MPFT is a huge organisation. We've got lots of capability within our trust, so we've reached out to all teams across health and social care and our mental health colleagues to see if anybody can offer a pathway into their service in the community for a certain set of symptoms. So all of our MPFT colleagues in teams have presented us with a template of what their services are available to do, and that includes hours of operation, what their criteria might be, what their exclusion criteria might be, so that when we are triaging patients we can look at those criteria and through that pathway development refer a patient into the right service. That's MPFT. We've also done that across other services, so social care, hospices. We're also looking at some work with the voluntary sector, so just widen and broadened what pathways we can develop so we can get patients an alternative offer.
Conscious of the fact that as we're recording this podcast, the NHS's new 10-year plan has just been published, and I appreciate we're going to absorb in the detail of that, but I guess my question then is what's next in light of the 10-year plan having been published? How can it continue to build on the good work it's been doing and keep patients safe and out of hospital? Angie? Yes,
so felt quite privileged actually when the 10-year plan came out, because as we were going through the areas that the health economy needs to look at over the next 10 years, we looked at our project plan and actually we were kind of geared up to that already. Yeah. It was like we knew what was coming. So we'll say that's what we knew what was coming. But yeah, so we've done lots of things already that helps the key aim of the ICC for urgent care is to keep people out of hospital. So the hospital to community is part and parcel of what we do in the ICC. And then obviously we've got analog to digital. So when we started working with the ICC, it was a paper-based service. I remember a visit from Martin Perry, and he picked a piece of paper up and said, "Angie, do we know what the piece of paper's for?" And I'm like, "Not really." So can we get rid of it?
Martin's our
director
of digital, by the way.
He is.
Maybe, doesn't he?
So he supported us to meet with the digital team and to find a digital solution for the ICC. And within maybe 3 months, we moved over to Rio, which is our clinical system. And from that, we now present a dashboard of every piece of data that we need to share with the ICB, with partners, but also it's sort of the really good work that we're doing, because what we then show from the data is how many of our patients have had an alternative pathway. So that's kind of really important for us to do that. Looking at workforce models and development as well. Over the past 12 months, we've started developing our triage competency framework, which we'll continue to do into the future. There's staff that want to go on and do that high level of learning, which Anna's working really closely with clinical colleagues and training to make sure that the staff in the ICC have absolutely got the right level of qualification and confidence and knowledge of everything that we need to be able to do the job that we want to do in the future. So we do feel like we're really on a good track to be able to get the ICC working in a different way. And when it comes to digital as well, we're happy to share our information with any other system so that we can make sure that when we're doing a triage for that patient, we know exactly what's going on. So we've got hospital systems, as Anna mentioned. We've got access to social care systems. We've got access to other community systems, so that we can take that information and make sure we can do the best offer for that patient as we can on that day.
And so, the 10-year plan, safe to say you're pretty much right at the heart of it?
Right at the heart of it, yeah, and clearly what we do as a programme team as well is go through that, as we did with the NHS guidance around single point of access. You go through and you self-assess yourself on where you're at and where you need to get to, and we've got a great transformation team that we know what we've done in 12 months. Increasing referrals, productivity is a huge part of the NHS plan moving forward. We've increased productivity by 63% in the last 12 months, which,
Very
yes,
good.
I know. It's really, really good. And obviously that's around looking at processes. It's looking at the pathways that we've now got available. But more importantly, it's that digital. It's that change to what it is that we do. We don't have 20 pieces of paper anymore that get passed around. There's one form in Rio that we can now use. So in the future, we will move forward and hopefully we'll have the information from other systems brought directly into Rio. And there is a big piece of work going on to use AI to bring other bits of info about patients from other systems into Rio, which is just going to be invaluable to us in the ICC.
And finally, all of this, as Angie's just described, everything you've just talked about, ultimately it all boils down to supporting patients to ensure that they get the right care they need, working together to that end. I suppose that's always the thing to remember, isn't it?
Yeah, it absolutely is, and also the slogan, Anna, for the NHS is go on, fire away.
We sort of mark ourselves on right time, right place, right care for patients.
Yeah.
And that's what it's all about at the end of the day. So thank you. Just leaves me to say thank you very much, both to Angie and to Anna, for joining us today. Really appreciate your time. Thank you. Thanks to Angie and Anna for their time today. It was really very much appreciated. You can subscribe and find other episodes wherever you listen to podcasts, and can also watch episodes by going to our YouTube channel. Check out the show notes for the link. It just leaves me to say thank you for joining us. See you next time.